Hello, my name is Erica Donison, and today I'm absolutely delighted to be speaking with Dr. Anikó Ball. Anikó is a dentist and Alexander teacher based in Melbourne, Australia, and she runs Optimal Dental Posture, which runs training courses for dentists and their whole dental team to help them carry out their work with more ease and less pain by applying the principles of the Alexander technique. She's the person behind the concept of inner ergonomics as a way of explaining the technique. But firstly, Anikó, could you please introduce yourself a little bit, and including how and why you got into the Alexander technique in the first place?
Well, thank you very much, Erica. It's a pleasure to be talking with you. So I was already in pain as a dental student, and the pain just got worse. Neck, back, shoulders, sciatica, hip issues, everything. And I practiced for over 30 years. I went to every medical doctor, specialist, physical therapist that I could find for decades. And they were all wonderful. They did their very best. What I now realize is that they were just treating my symptoms. And it never occurred to me that perhaps my pain was because I was doing something in my work and away from work. I just thought it's my bad luck. I didn't realize that most of my colleagues were also in pain. Back then, people didn't talk about this. We suffered in silence. And I was forever canceling patients. 20 odd years ago or 30 years ago, I felt like a 100-year-old woman. I couldn't even get to my shoelaces. I have to wear slip-on shoes because I was in so much pain. And it was after I was finally declared, probably 15, 20 years ago, a hopeless case by my doctors and physical therapists. And in desperation, at a time when I wasn't into praying, I prayed for help. And I found myself a few days later in a bookstore and picked up a book that stayed in my hand, and it was about the Alexander technique. And in the introduction, I realized that this is for me. That one of my patients who I'd been seeing for several years turned out to be an Alexander teacher. And I went to see him, and I thought there's something in this. I was never planning to do the training because it had to be, as you know, 3 years full time, and I was a practicing dentist. Luckily, in Australia, they decided 3 years later to allow a special case like me, and I was the first person they allowed to do this over 40 years part-time. So I continued to practice part-time dentistry and did the training over 40 years. What became very clear to me, Erica, which made me almost drop out of the course very early on, was that the way I was learning was the learning style of the performing artists and musicians. However, it wasn't ever going to cut with the dental audience. Our learning style is very different. It has to be very clear, very practical, and I feared that I wouldn't be able to do this. Then I realized that I had to translate what I was learning to the learning style of my profession and dental industry-specific application. And so I probably spent another 1,000 hours, if not more, on top of my training to be able to do what I'm doing now. And the reason why I trained with one intention, and that was to help my colleagues, to bring this to the dental profession. I was so passionate about sharing this with my colleagues that although my plan was to practice part-time dentistry and also set up optimum dental posture and give talks and presentations and run workshops, after some time I realized that there were enough dentists saving teeth. Someone had to save the profession. And so I stepped out of clinical dentistry because I could see that there is such a need.
Well, it's wonderful, isn't it? Because what you're doing is helping dentists stay in the profession for longer.
I love this. I'm a frequent presenter at dental events, conferences. And one year back in 2019, when I was invited to present at a congress, and I usually give a brief of what I'll be talking about. And there was a topic that the Congress committee chose, and that was inner ergonomics, a practical recipe for career longevity.
Yeah.
I had 400 dentists turn up to listen.
Yeah, I bet they did. Brilliant. Thank you for that. That's really interesting how you got into it in the first place. So you've touched on the problems that you've experienced, and I was just wondering what it is about dentistry and the way that dentists have to work that is so difficult physically. And looking at that slightly differently, what does that mean for dentists? You know, what are the sort of physical problems that they experience from their work? So what are they doing, and how does that manifest in their lives, pain-wise?
So the problem with dental work is that we have a patient whose mouth or head is situated somewhere around just above our thighs when they have their head on the headrest. And we need to get into the various parts of their mouth. Unfortunately, we don't learn in dental school that you can't just twist and bend like that. Every dental student does that in order to get the work done. The teachers, demonstrators who train us in dental school do the same, so we copy them. We don't think about what we're doing to our bodies. So it's a matter of trying to get to the mouth from up here. And in fact, when I look back, I think that the way I used to work, and this is how most dentists work, it's like we are a disembodied pair of hands, eyes, and the brain, and the rest is a black box, it's a vacuum. We don't even think about it. So it's getting visual access and manual access into the mouth. Also, we are in a small space, but because the dental nurse also has to fit in on the other side, dentists can't get into proper positioning because they're too afraid to ask the dental nurse to move. It's great when I can train both the dentist and the dental nurse. And having to reach for things, there's a repetitive picking up and putting down an instrument and twisting. So the actual physical nature of it is hard. And also, we are working on a moving target. Any moment the patient can move, lips, tongue, and we are using sharp instruments or rotary instruments. And there is this vigilance because we have to step off a foot control or watch a sharp instrument any second. And that means that there is a physical, mental, emotional tension in the dentist's body and mind. And also, a lot of patients are frightened, and that's kind of infectious. But I also include a segment on stress management because you can't separate the two. So dentistry is very stressful at so many levels.
Yes. So presumably the physical problems that dentists kind of present with can be many and varied, could be anything.
Usually it's neck, back, shoulder pain. I had burning left shoulder, so most right-handed dentists and hygienists have problem on the non-dominant side, so left side, because that side is holding a mirror and it's stationary. And of course, you and I know that movement muscles are not designed for lengthy contractions. So,
Yeah.
and sometimes on the right side as well, but it's neck and back pain in particular that will stop them.
Okay, so let's get on to your way of working and your terminology. I'm kind of intrigued by what you said earlier about kind of putting it into dentist speak, as it were, so that they will understand the principles of the technique. So the research I did before talking to you today was around, you know, what is out there, what is happening to try and help dentists. And what I found was that there's stuff about you know, using a saddle chair and sort of getting different equipment in. So I'm wondering whether you could say a bit about how you speak to them, your inner and outer ergonomics terminology, so that you can teach them how there is another way so they can help themselves.
Well, it occurred to me during my training at the Alexander Training School that there is a massive amount of money going into research and development in dental ergonomics. And it became really clear that it's all about what I decided to call the outer, everything but the dentist. And I say, outer ergonomics is everything that's not you. And it is important. What I focus on, the dentist is doing inside themselves, the how and the way. So what I always say is, how you bend over to look into the patient's mouth, the way you hold the instruments, what you're doing with your arms is just as important as the equipment. And in fact, you could have the Rolls Royce, the very best of dental equipment, and still twist into a pretzel. You know what a pretzel is?
Mm-hmm.
That's
Yes.
what I used to do. And I actually have a bendy ruler that I twist like this, and they cringe. And I say, well, it hurts me to do it to the ruler, and that's what you're doing day in, day out, and that's what they're doing. And they get it. And I talk about organizing yourself from the inside. In dentistry, we call wherever the dentist sits in an o'clock position. So right behind the patient is 12 o'clock. And they ask me often what o'clock position and what angle should they bend for whatever tooth they're working on. And I said, if I answered that, I'd be giving you outside-in information. What I'd like to do is to teach you what to do and not to do with your body, how to organize yourself from the inside, and then you will know where to sit and how to move things. So that's the difference, and they really get it. And initially, I wasn't planning to spend as much time looking at outer ergonomics as I ended up doing, but I realized I have to be very conversant because I'm constantly asked what I recommend and what I don't. And there are two items that I call an inner and outer ergonomic interface, and they're very important. One is the dental stool that the dentist sits on. It's got to be right. Dentist needs to know how to sit, but the stool has to be right. And the other is magnification loops. They have to be right. And unfortunately, I discovered when I first started looking at all this, probably 10 years ago, that there were major problems with both.
Following on from that, I mentioned to you that I have a friend who's a dentist, and she said exactly that she'd made some changes to her outer ergonomics, like putting equipment in a place that was easy to reach. So she'd worked out, I mean, she had shoulder and back pain, I think. But the surgical loops, the heaviness of the surgical loops, which apparently sit on your head, were causing her, sort of to pull her neck forward, her head forward, and was getting a lot of pain through her neck and shoulders. Have you gone to manufacturers and said, this is causing dentists a problem? Is there something we can do about this?
Well, I have. I wasn't shy after all my suffering. Probably 10 years ago, when I first realized that most stools were too soft and not well designed. And I approached several manufacturers and several companies that distribute them. And I was so polite. Some of them were offended, even though I was very polite. How could I possibly suggest that their stool could be improved? And I said to them that if you just made X, Y, Z changes, and it was usually to make the seat more firm, so using high density foam and just a very slight forward tilt so that the legs can be released from the hip joint. And also back then, unless you had a microscope, you couldn't sit upright. But when, say, a dentist was just talking to a patient, to give good upright support, almost all the stools had backward sloping backrest. And when they weren't listening, I ended up designing with a very experienced Alexander teacher, Karin Chapman in Brisbane, who has been my very dear friend and mentor. And she and I designed a vinyl covered wedge that can sit on a dental stool to improve dental stools when none of the manufacturers were listening. And also we designed a high density foam wedge cloth covered for cars, because a lot of cars have got backward sloping seat.
Indeed.
A few years later, one of the companies based in Melbourne that manufactures dental stools contacted me and asked, well, Anikó, what were you going to suggest if we were going to improve our stool? And they actually created a stool based on Karin and my recommendations. It's called the Dr. D, D for dentist, dental stool. And it's exactly what I recommended back then. And now it's available. It just looks a bit odd because it's got this wedge-shaped seat, and dentists need to be educated about it. And many have bought it, and also a lot of them have bought the wedge. Because once they sit on a firm, high density seat, you know very well that when your system receives that firmness, because the sit bones need that firmness, then they know exactly what we're talking about. And you mentioned the saddle stools. I'm not a fan of saddle stools. A lot of dentists love them, especially male dentists. I don't love the idea of having the sit bones on a curved surface. And also, for most women, the stool is too wide. It pushes their thighs apart. So they're not really well designed, but some dentists love them. As long as they like it, great. So dentists who were slouching before, they tend to not slouch so much on a saddle stool. However, the big problem is that dentists sit upright, and then with or without loops, they bend forward around C6, C7. In fact, a lot of dentists had to have spinal surgery around that area, or have been told that they are going to have it because they're all bending here, and sometimes they bend along the thoracic spine. So this is a common problem.
So my next question is around the research study that you were involved in, that was sadly never written up. Can you speak a bit about what you were looking at, and whether you might or are taking part in some research in the future?
Well, I was approached by a lecturer at Melbourne University in the oral health therapy department, and Melanie Hayes. She wanted to see if the inner ergonomic training was going to improve the physical and mental well-being of oral health therapy students.
Okay.
And this was going to be written up, and we're going to present it at dental events. So there was and we're going to do further research. And so I ended up giving a half day. I always do a theoretical training first. I explain the basic ABC of how the body was designed to work, and what to do and not to do with your neck and back, shoulder and arms, legs. And I teach functional anatomy, body mapping, and I teach directional thinking, giving directions, and I go through all of that, and then we put it into practice. So what I did with about 50 oral health therapy students was to teach the basics, and then I took them into the student clinic, and we put it into practice around dental equipment, with mannequin and mouth. And I did that over, I think, 3 or 4 sessions in smaller groups, and they all had lots of instructions. So there were surveys done on the amount of pain and where they were experiencing it before we started. And I always ask for a show of hands wherever I am. Put your hands up if you're experiencing, pain, discomfort, stiffness, numbness, tingling, whatever. In any body part, and then I go through the body parts. And I remember the faculty was sitting the back of the room, and of course, and these were only students, so they were not working full time, just in student clinic some of the time during the week. And every single person put their hand up for almost every location I named. And I could see that the faculty was shocked. They weren't expecting that. And this is what happens wherever I go. I usually ask, when I have a very large audience, is there anyone who didn't put their hand up? And there's never a person. I also did a special training for the faculty so that they could support the students, and they all loved it. And then they did follow-up surveys on pain, and everything was done. And then Melanie was headhunted to be the CEO of the hygienist organization in Australia. And she left, and I begged her to give me the analysis of the data, and she refused. So that's why it was never published.
That's very sad, isn't it? It sounds like there was a lot of work gone into it, and actually it could have shown some really, really useful results.
Yeah.
So, what's coming up in the future then?
Yes, well, there's something new, and I'm really excited about it. A dentist who I had in my one of my first workshops when I started running workshops, got so interested in inner ergonomics, and then he decided to do a master's degree at Queensland University, and which then turned into a PhD. Uh, and he's approached me just recently that what he would like to do, the research for his PhD thesis, is going to be putting these sensors on various muscles, studying the amount of muscle activity in various body parts of dentists, and also correlating the amount of pain they report before they hear me talk. And then now, unfortunately, I will only have 2 hours with the dentist.
Mm,
But in those 2 hours, I'm going to teach them all the basics of what to do, not to do, directional thinking,
mm,
and then and also I'll take my mobile dental chair along to the lecture room and my mannequin, and I'm going to demonstrate. I always like to do a lot of demonstrations.
mm,
And then there'll be an assessment of any changes that can be picked up and reported in this study. And what is really exciting, my friend Stefan, who will be doing this research and writing it up, he said that he studied world literature on any ergonomic intervention in dentistry to reduce musculoskeletal disorders.
mhm.
And he said that it's never been written up exactly what was being taught. So there's no way of knowing. And what he said is that he's actually going to write up what I am teaching so that it's reproducible to whatever degree, or at least people know that that's what was being taught. And of course, the Alexander technique, the inner ergonomic principles of the Alexander technique will be written all over it. So I'm very excited. I wish I had more
Mm.
time with the clinicians, but this is a beginning, and hopefully
Yeah.
there will be more. Or my dream is that this training is available in dental schools. I'm often invited to
Mm.
give talks in dental schools. At times I'm given opportunity to demonstrate, and the faculty always says, "Oh, this is so good. We need this." And I say, "Well, please put me into the curriculum." "Oh, we don't have time." I said, "Well, reduce the amount of physics, biochemistry and pharmacology." "Oh, no, we can't do that." "Well, let me tell you that they're not very useful. They could cut it back."
Yeah.
Eventually, I'm sure that this will be part of the curriculum. It needs to be.
Mhm. Yes, get them before they start. That's the thing, isn't it? Before they end up as wrecks. So my last question is that we know how difficult it is to change habits, especially as we've already been talking about the equipment you have to use is challenging, and you're under pressure to stay within an appointment time. And as you said earlier about the fearful patient, these are huge stimuli that dentists have to cope with. So I'm just interested in how you put that across for them, because they're obviously, I would imagine, your clients that you're working with are kind of going, well, there's all this I have to deal with. How am I supposed to think about that as well? And yeah, so how do you teach dentists inhibition?
Well, it's a good question, and something that I begin in a 2 day workshop, for example, almost halfway through before morning tea,
Mhm.
is habit change, because as I'm teaching, I start with functional anatomy and body mapping and starting at the top joint. And already I start talking about what people do to look at a mobile phone. I always take out my bendy ruler and tell them what they're doing. And then I say, well, you've got a wonderful joint called the elbow, bring it to you. And then I talk about habits. that you only have to do something a few times, and then you've got a software called That's How We Do It. And then I tell them that unless, and by this stage I've already talked about inner and outer ergonomics and the how and the way you do what you do. And I talk about the importance of starting to pay attention to how they do what they do away from dentistry, because if they can't become aware of how they look at their mobile phone when they're not doing dentistry, there's no way that they can notice and break harmful work posture habits. That's the expression I use, harmful work posture habits in the clinic when they have the time pressure and the patient present and the complex treatment. So I ask permission to come up to them and do that in the morning tea break, and I'm doing that all the time, and they go, sorry, and I said, don't be sorry. This is, you need to become aware that this is your habit and that you need to break that habit. You need to change it. So ask the people you live with, work with, if you don't notice it, to remind you. And I really drum it in that it needs to be away from dentistry first. And if they can become aware of how they reach for the salt when they reach across the table instead of doing that, or everything away from the clinic, then they have their chance to make changes in the clinic. And for that reason, it's really helpful to train a whole team, because I find that a team that trains together can support each other in habit change.
Yes, so it's perhaps forming a culture where people are, so the dental nurse and the dentist are able to kind of go, did you notice that you just did that thing that you're not supposed to do? You know, that sort of thing. Because I'm wondering whether there's a dynamic in almost a hierarchy in the system where the dental nurse might not feel safe or able to sort of point out something. So it gets really interesting, doesn't it? That getting that culture of people being open and happy to help each other.
It's interesting that you mentioned that, because I love it when I go out to a practice. I train, always there has to be a permission, whether it's somebody you live with, otherwise you're nagging. If they don't give you permission,
Yeah.
remind them. And then I train the dental assistant that whenever the dentist comes off the vertical, because they're forever doing this, to wave or do something.
Yeah.
Because this feels so natural and normal that the dentist won't even notice. Whereas the assistant, I tell them what to look for or how to tell if they're looking down from the top joint or using C6, C7. And what happens is that it's actually very interesting. I didn't expect this. The first time I did a team training, I realized that it's a wonderful team building opportunity. Also, the dental assistants, who are often not appreciated and made to feel important enough, suddenly feel very important, because they can help the dentist break habits. Also, the dentist, provided they get on well, can help the dental assistant. So it's an excellent opportunity. And when I train a practice, I take additional dental trainers with me, Alexander teachers who have trained how to assist me in a dental practice. And also in my workshops, I have assistant trainers. We train them together so that, in fact, what we often do is I'll be standing behind the dentist, Karin will be behind the dental assistant, and then we do hands. So I call it hands-on kinesthetic guidance. I teach as much as possible. I talk to their thinking so that they can do it for themselves, but we guide them so that they have that muscle memory, and also we fire optimal neuromuscular pathway. And so we guide them and teach them how to do that.
That's absolutely wonderful. Thank you so much for speaking with me today. And I think we've got a lot of information to process in this for people who, whether they're working with dentists or not. Thank you ever so much for that. And yeah, thank you for your time today. It's been wonderful.